I'm going to speak to you from the experience of collaboration across subspecialties. The surgeons are a fair distance further down the road than you all are. But the opportunities that you all have to catch up in this game are really many. And some of them are really going to be very fruitful if you focus attention on doing it. So what the surgeons are now doing is in spine, they've had a series of successful registries. Here in Washington State, 3 of them were launched, and the national one, the American Spine Registry that has neurosurgery and orthopedic spine surgery in it, was a copy of our Washington State Registry. Washington State Registry now has somewhere in the area of 45 to 50,000 patients in 2-year surveillance. So, and it's across a series of diagnoses which you all participate in. Hence, it's something that's low-hanging fruit for you. So it's degenerative disc disease, spinal instability, spinal stenosis. The excluded categories, and you'd be wise to exclude yours as well, are trauma. It's highly variable, and tumor. So that also is highly variable. So if you're going to embark easy territory, lumbar spinal stenosis with or without instability, because you have separate ICD-10 codes for them, and you have separate CPT codes for how you will treat it. But if you were to do that, you would be able to compare your impact in the techniques that you've mastered to the surgical techniques, which are in 2 arenas. They're inpatient, and Doug showed you the reimbursement codes associated with inpatient procedures. They're substantial. And the ambulatory arena, where many of those surgeries are transitioning. The second arena that orthopedics has done well in is joint replacement. So the American Joint Registry, AJR, has now 4 million patients in surveillance, and the payers are partnering with the American Academy of Orthopedic Surgery to help guide the transition of inpatient procedures to ambulatory settings as a cost control measure, but understanding that the ambulatory arena has to be paid sufficiently for margin. But when you're looking at the cost savings associated with an inpatient procedure, they are so substantial that in appropriately selected patients, that's the way to go. And so the payers, and you are now going to practice in the era of the power of the payer. The payer is going to tell you what will be authorized, not be authorized, how much will be paid, what you won't be paid, what can be used, what cannot be used. And the only way you can take that away is if you have data. And that's a slide about generating collaborative data. And what you notice is the only one of the 5 that is in all capital letters is the most important thing you have to do. You have to own your data. Because if you are working for a health system and they own your data, you don't have control over it. Or if you're working within a closed model, that closed model, Kaiser, Group Health, that closed model owns your data. So you want to own your data. The other small steps are starting small, making positive wins, staying on a diet. So if there are 10 metrics out there, start with 3. Make sure you get 100% data capture on those 3. So pain, function, and what was the widget that we were using in this vertebral compression fracture. And then whatever that widget is, how many companies make it? Okay, every one of them. And all you want to do is just check the box of which company you used. And what you'll notice is you'll have massive amounts of data very quickly, especially if all of you join in and do that. Or spinal cord stimulation, classic area. Make sure that you have the same metrics that other non-interventional clinicians use to measure. So, what do surgeons use to measure? We want pain, we want function, we want adverse events. We also pay attention to costs, so we put that down. So just to, went the wrong way. So here's an example of registry being used in general surgery. And they ask the simple question, does a leak test when you do right colon resection, do you do a leak test? Because if you test your anastomosis before you let the patient, all you do is just open the abdomen, do the anastomosis repair, place a rectal tube, and blow air onto your anastomosis, fill the belly with water. If you see bubbles come up, just like when you were a kid and you were fixing the flat tire on your bike, that's why there's a bicycle in the background of that slide, is to remind you that you already know how to do this. If there are bubbles coming up from that inner tube, you still have a leak. Got to take the tube, fix it again. If you have bubbles coming up in the abdomen, you have a leak. You trace down to the bubbles, you put a stitch at the bubble, the bubbles stop, you've cured it. If you don't do that, that patient is going to come back to the emergency room, be readmitted to hospital, in sepsis, go to the ICU, and die. So you need 5 metrics in following whether you do or do not do leak testing. You will have similarly 3 or 5 metrics for each of your procedures. And what you'll see is that people who do leak testing, less than half in 2005, down around 40%. And by the time this registry had tracked all of the general surgeons in our state, 100% of them, 6 years later, 100% of them are doing leak testing. And the hundreds of millions of dollars of adverse event management disappeared. The governor gave these surgeons awards for this kind of work. And you can do that. And because it benefits your community, your practice, your subspecialty, and all of your patients, it's a really smart thing to do. So let me see if I can, here we go. Oh, this is it in spine. When you do it in spine, this is when the registry had 27,000 patients in it. We selected 1,536 of the 27,000 because we wanted complete data sets. So you got to have complete data sets. Small thing, but in medicine, a complete data set is much more powerful than a massive data set that has 40% missing data. A complete data set is important. What we were able to do is we were able to predict. So this is a JAMA article showing you, I can predict the outcome of your spine surgery or your spine surgery or your spine surgery before I operate on you. And in this particular instance, what you see is we developed a computer module that you can use in the office. As you can see here, this patient has a 13%, the histogram, the gray histogram on the side, on the right, has a 13% likelihood of success. And here on this are also listed the metrics you should use in any registry that you developed. And you'll see that they're very easy metrics to use. Mr. Pointer, there we go. Okay, first age, that's a pretty simple thing to do. Sex, that's a pretty simple thing to do. Always remember to know your insurance type. Because what this predictive paper published was that the Medicaid population and the L&I population had a 17% predictive deterioration in potential outcomes, no matter which surgeon or what procedure was done. The head of labor and industry called me and asked, Neal, why are you, this is recorded, right? So he made a derogatory comment about the paper. And why are you, calling me out? And I said, well, you should look in the mirror in the morning because you're the responsible person who has caused this deterioration in outcome. It's associated with your payer system. That means it's your baby. That means it's your fault. It's not the fault of the surgeons. And I didn't go through the list of the surgeons who were on the paper, but they're all the cream of the crop in the state of Washington. Whether in university or whether in this facility, these guys right here, or community or other health systems, all of the best surgeons were on there. And what it showed is the surgeons don't have a difference in outcomes. The types of patients cause the difference in outcomes. So when you look at this, it does matter your age. It does matter your payer status. Who are they? And then importantly, under these diagnoses are listed here, but I don't know why they're not showing up, are things like, is it a virgin or a revision procedure? That's important. Is the patient on narcotics or not? That is important. Does the patient smoke or not? If you're walking into the effusion arena, you need to pay attention to that. Is there a comorbidity associated with abnormal healing, diabetic? You need to know that because it impacts. And so what ended up happening is the reason that this patient has a 13% likelihood and everybody else has a 64% likelihood is because of success, is because their comorbidities. You heard Doug mention to you the importance of comorbidities. The comorbidity, we call them modifiable factors, but the comorbidities are important. So whenever you build your tools, you have to include these. And then how severe? If somebody's got a 5 out of 10 pain scale and they only get low back pain when they're carrying a case of beer out of the AM/PM market, but they don't have sleep disruption, they don't have 8 or 9 out of 10, I didn't put the function scale ODI or NDI or Promise 10, whichever one you want to use, they all work. These are impactful for predicting. And if you know the predicted outcome of your patient before you treat it, and you have a whole series of colleagues who are collecting that similar data, so you, instead of waiting for the 400th patient in your practice, within 6 to 8 weeks, you have more than 400 patients across all of the practices that are involved in the registry. Very quickly, you get into thousands in your N number. You get up to the 5,000 level, you're now in trending. That's the territory where you can take your data to the insurance company and say, these are the trends, and when we take these numbers into the 20s, 30s, and 50,000 patients who have had these procedures, you're going to be able to predict their outcomes and the costs associated with it. It's huge. It's huge. And I'll go back to this one. This is the world's largest vertebral compression fracture registry. Some of the folks that are in this room here teaching you are co-authors on this paper. And what this shows is that you can have reliable safety. Kyphoplasty has an adverse events associated with the procedure, not associated with the age of the patient. You know, some of these elderly folks are going to have their own, but associated with the procedure, it's a very safe procedure. Very safe procedure. Combined adverse events, even though cement leakage is not a problem, you need to pay attention to it because it's giving you a clue about the personality of the fracture. If the personality of the fracture is cement wants to leak out to the right, to the left, to the front, it's also going to want to leak out to the back. And that is, alarm bells need to go off associated with that. But you have remarkable deltas in pain and function, meaning this is highly successful. And there's a vulnerable population of elderly women who benefit from this. The pain scores improvements, that's the upper scale. The function improvements, that's the lower scale, are dramatic, and most importantly, they're sustained. So when you go before a payer and you want to argue for the reimbursement of this or another similar procedure that you've enrolled in registry, this is powerful data. It changed when presented to Medicare Max in 2020, it changed national authorization policy. And authorization is access. If the patient gets authorization, they have access to you. If they don't get authorization, they don't go through your door. So it's important. And then this is, you can promote somebody's interest besides yourself. So this is the patient getting dramatic pain improvement. And what you're seeing here is that the quicker you get to the patient, the less expensive the procedure is. So if you get to see the patient, this is a patient of mine who came in the day she broke her bone, was fixed the day she broke her spine. And this is a patient who came into my practice 6 months later. Notice the tripling of costs. And you can relay that to the payer because they're the ones who are hemorrhaging that cost. They're paying 3 times as much. And you still have, pain, disability score goes damn near to zero, pain score goes almost to zero. And you notice here that the disability score is 3-fold higher in delayed treatment than it is in acute treatment. So from a payer, especially a national payer, those are higher disability costs. You're going to see that in narcotic use. You're going to see that in disability payments. So it's really impactful. Similar principles were used for a sacroplasty registry, and they showed the same thing. The augmentation is genuinely beneficial. You are going to be competing in your generation with the surgical specialists who are now engaged in registry. Then their registry is nationwide, and it has the same power as the statewide registry in Washington State that you saw published in the JAMA article, because they copied and ours is a copy of Peter Fritzell's Swedish spine registry. Peter came here and helped us get that done. And SweSpine's got in their 40th, 50th year now. But anyway, these surgical societies have written a consensus letter that basically says we don't think non-surgeons should be doing fusion procedures. And how many fusion devices did you look at this morning? So you are clearly looking at NIMBY, not in my backyard. Instead of collaboration around how do we develop a spectrum of care where we can have lower costs but genuine safe outcomes and catch these patients before they get to the only and inevitable knife as their options, you need to develop registry tools that exactly parallel with the surgeons. So your pain score should be the same. Your dysfunction score or your disability score should be the same. So whether you do NDI or ODI or PROMIS 10 should be the same that are in the publications. Your timelines for treatment, your diagnoses should be the same. So that what you're doing is apples to apples. And you should do the same thing that we did with Medicare, have the cost data. You're already advantaged. Where do you do your procedures? In a low cost, low capital environment. And so you're going to, in the apples to apples comparison over the next decade, the transition to interventional spine treatments are going to be dramatically large. And if you have these measurement tools with significant N numbers within them, you're going to be empowered, remarkably so. So food for thought. When you go into the surgeon's arenas, you have to have an understanding of biomechanics. As you can see, that plane ain't going to fly. And when you're doing heavy lifting, you got to know how to do it and to do it right. So using a registry tool to move graciously and collaboratively into an arena that is shared by many, many physicians with gifted minds and substantial egos, you want to be in a place where you're making your good work known and avoiding difficult circumstances. Those are the registries that I spoke of, the American Spine Registry, the Vertebral Compression Fracture Registry. That's what successful collaboration looks like. And then I'll close with this. In doing registry work, there are essentials. And the most important was the big red one that had all capital letters, own your data. Be in control of your destiny. And transparently reporting. The best way to generate trust is to tell the truth frequently. Publicly. That's transparent reporting. The Hawthorne effect is really the simplest methodology for demonstrating to humans the goodness of what you do. And Hawthorne is just analogous to taking a flashlight and turning it on in the center of a meth den or opium den. All the cockroaches run to the corners. So when you show your data transparently and just shine a light on it, the goodness of what you do will be evident, and the benefit of what you do will be evident, and the mistakes that are there will be evident, and you simply find the mistakes. So we did this in spine surgery, looking at diabetes management. What's the blood glucose coming in? What's the blood glucose going out? Of the hospital, not the operating room, of the hospital. So that you don't take a patient with a blood sugar of 800 or 600, 400 or 300 into the operating room. You fix that fixable, modifiable characteristic. You fix that before you go in. You get their temperature right. The antibiotics are given on time. These steps, which are particular to your practices, will be part that you will share and measure amongst all of you, and so that you're all on the same page, same sheet of music, doing the same thing, whether it's in Oklahoma or Arizona or Washington, it doesn't matter. It's the same caliber of care. You'll make sure of that. And then when you publish across subspecialties. So the JAMA paper, orthospine, general surgery, anesthesia, neurosurgery, whole bunch of gifted medical researchers, put them at the front, so that you have a broad collaboration in the author list, because it speaks of collaboration without that word being in the paper. So you've enhanced your relationship by doing that. And the rest of it is just take the time to do it, because it's going to be, when you're in control of your destiny, you are so much happier than when someone else is telling you what you can and cannot do and why you can and cannot do, and they haven't got a fraction of your education or your dedication to your community. Any questions? I'm done. Should be. Yep, I'm done.
Okay, you did this.
Thank you, Ben.